I'm really truly honored to present that on behalf of my colleagues. We were a research consortium of 6 study groups in Europe and Israel, including 11 countries in Europe working on this clinical trial. Here are my disclosures. And just as a short introduction for those who don't treat CLL patients daily, so when patients achieve advanced stage, our treatment decision in Europe at least is guided, as shown here, by the EHA guidelines according to genetic risk factors as TP53 operation, mutational status, but also to the age and fitness of the patients. And as you can see, for elderly or unfit patients, we have the option between targeted treatments, including long-term treatment with BTK inhibitor, as well as time-limited treatment with the BCL2 inhibitor, venetoclax, in combination with obinutuzumab, based for the latter one on data from the CL14 trial in this elderly patient population. We do not yet have data in a randomized phase 3 trial for the fit patients on venetoclax plus obinutuzumab, and therefore we treat those patients in many countries in Europe either still with chemoimmunotherapy when they have a favorable karyotype, or favorable IGVH status, or with continuous treatment with BTK inhibitors. And therefore, we as a research consortium in Europe wanted to address the question within this 4-arm randomized trial in fit patients who were selected by a fitness score as well as normal creatinine clearance between the standard chemoimmunotherapy with FCR or BR, and due to that all patients were centrally screened for TP53 mutational operation and were then excluded, or 3 different arms, all of them containing 12 months of treatment with venetoclax. And the study has 2 co-primary endpoints with an alpha split to 2.5%. The first endpoint was already met last year. That was the rate of undetectable MRD at month 15 in the peripheral blood measured by flow between venetoclax, obinutuzumab, and chemoimmunotherapy. And we will present here now the second co-primary endpoint, the PFS interim analysis for a triple combination combining venetoclax, obinutuzumab plus ibrutinib, given also at least for 12 months with a possible extension up to 36 months. And there was also a 4th arm, venetoclax plus rituximab, included, which was also allowed to be analyzed according to a statistical hierarchical ranking. So overall 920 patients were included, and now after follow-up time of 38.8 months, we see the interim PFS analysis here that with the black curve, the triple combination venetoclax, obinutuzumab plus ibrutinib was clearly superior to chemoimmunotherapy with FCR for the younger patients or BR for the elderly patients who were fit, with a hazard ratio of 0.32. Also, the venetoclax obinutuzumab therapy was clearly superior with a hazard ratio of 0.42, but venetoclax plus rituximab was not superior. So it depends also on the antibody which you combine to the venetoclax treatment. Looking at the 2 major subgroups in CLL, patients with mutated and unmutated IGVH status, on the right-hand side, we see again that particularly prognosis is favorable for patients with mutated IGVH status, where there's not such a big difference between, in blue, chemoimmunotherapy and the targeted agents, but we see a huge difference, particularly for patients with unmutated IGVH status. With respect to the side effects, shown here all CTC grade 0 higher side effects in 5% of the patients. There were no major difference, particularly not between the 2 arms containing venetoclax plus obinutuzumab, with the exception of higher rates of infections and febrile neutropenia with the triple combination as well as with the chemoimmunotherapy. With that, I would like to summarize the results of the study. So time-limited targeted therapy with venetoclax plus obinutuzumab with ibrutinib or without ibrutinib is superior to chemoimmunotherapy with respect to PFS, also with respect to undetectable MRD rates. In particular, patients with unmutated IGVH status benefit from this targeted therapy, and higher infection rates were seen with chemoimmunotherapy in the triple combination. And the question with respect to the head-to-head comparison of the triple arm versus the doublet arm, what is the additional benefit of ibrutinib? We will be able to analyze that next year with the next follow-up.